Okay, well, thank you, Dr. Kaiser, for joining us again. I know you have a busy schedule. You've been very busy. I just want to thank you once again for taking a leadership role here out in Riverside County. You're ahead of the curve again here with the masking policy for the public. I want to, personally thank you, and also for being ahead of the ball game, way when this began in the beginning. Uh, just to remind everybody that you should be muted. I will be reading the questions to Dr. Kaiser. And once again, we're going from 6 to 6:30. Dr. Kaiser has some other engagements he needs to go to. So I'll start reading the questions. Dolores, is there any other ground rules that we have here that I need to be aware of?
No, I think we're great. Thank you.
Okay, so we'll start with question 1. Real life question. 2 employees downstairs in our multi-specialty building who work at entrance to our building are now documented COVID-19 positive. One last Thursday and now on this Monday. It's my understanding several exposed pharmacy employees are still working with gloves and masks. My understanding was the health department was notified. CDC recommendations clearly state all exposed health providers should be on self-quarantine when known exposure occurred. However, it appears our county overruled the CDC. I am concerned for patients whose scripts were filled while both employees were asymptomatic. And why does the Riverside County Health Department overrule the CDC? I am concerned for patients whose scripts were filled while both employees were asymptomatic. And why does the Riverside County Health Department overrule CDC and let these other exposed employees still work? Other pharmacies are within a mile and still open, so not an issue of not getting scripts filled. Why did the health department let this happen?
Okay, there it is. For some reason, I was muted.
Oh, that's okay.
There's actually a very simple answer to that question. The governor's executive order of March 15th actually requires that healthcare workers and first responders who are asymptomatic be allowed to continue working during the quarantine period. I can certainly make reasonable requests for infection control and impose certain requirements on that. That's why they're in gloves and masks. That was a local determination. But this is also a statewide order I am required to comply with and is not merely a recommendation. As long as they remain asymptomatic, the governor's order requires that I let them work.
Okay, well, thank you. When do you estimate the California stay-at-home directive will be lifted? And do you anticipate a second wave of infection when this is lifted?
Okay, I'll just leave my mic open between them. There's a couple stuff going in the background, so I hope people don't mind the noise. You may have heard that the school closure order was extended to June 19th. This was based on the advice of the superintendents due to the governor's remarks that school will not reopen. I can interpret the governor's remarks as saying that I don't anticipate he's going to lift much of anything before May, and it is entirely possible that the order may remain in effect until June. Given that we'll be in a very different part of the year, I think it's too soon to tell if we will have a second wave at that time. I know that there have been concerns in some countries that they may have opened up too soon. It's entirely possible we may be in that situation, but I don't have enough evidence to make an accurate prediction right now.
Okay, before we go further, would you like to just give an update, just kind of a generalized update to the other physicians before we go on to the third question?
Sure.
Okay, thank you.
As far as the current county situation goes, as you may have noticed, we continue to have a substantial rise in our local cases. We are now currently at a grand total of 493 with 14 deaths. And then we have also started counting our recovered individuals, and that number is currently 50. Although the cases initially started in large quantity in the Coachella Valley, the vast majority have now moved over to the west side. We are seeing some similar trends locally that we have also seen worldwide. For example, there is a predominance in male cases as opposed to female. We don't have a clear explanation why that is. I don't think anybody does right now. And the majority of our cases continue to be in the 40 to 64 age group. There are tails around it. Pediatric cases, again, are extremely small, which suggests that they are either not being tested or don't have symptoms that cause people to think they need to be tested. And I think that's something we've also been seeing in other countries as well. In the news, I know many of you have heard that we had our first deputy death due to this, and we also currently have an outbreak in the Koisberg detention facility that is being managed by the Sheriff's Department in consultation with us and the rest of our UHS. Managed to get most of the people tested. One of the wards is in quarantine. And currently we have not seen any additional cases, but there are still a large number of pending tests to come back. We're also dealing with our second nursing home exposure. We had a first one out in the desert. That one has concluded, but the second one, we completed testing of all the staff and residents today. Those tests will be run through our public health labs so that we have custody and can expedite those test results as quickly as possible. People should be aware that the testing situation continues to be highly limited. If you test through one of the commercial labs such as Quest or LabCorp, you're still probably looking at close to a week to receiving those results. We are looking at some various point of care ones, but these require a substantial outlay in equipment. And as I'll mention a little bit later in some of the questions, pretty much all equipment purchases are right now a seller's market. We're looking at a couple of possibilities for maybe doing this through titers, and there's at least one promising point of care test that we're looking at, but we need to have a clear idea of exactly what performance characteristics that would have and whether it's directly comparable to the RT-PCR testing that we're doing right now. We update our statistics daily. That's at rivcoph.org/coronavirus. There is a map there as well so that you can see the relative impact throughout the county. All orders and as well as health advisors are also being posted to the same page. And our public affairs group tries to make sure this is pushed out through social media as much as possible. In addition, you have heard about the cover your face order. You'll notice that I am avoiding saying the word mask. That's because we are trying to reserve as much as possible masks for healthcare providers, first responders. I'm still seeing an awful lot of masks and N95s and a lot more than I would like to be seeing outside of a healthcare setting. But nevertheless, it does appear that many people have taken the messaging to heart. However, it is also clear, and I think that the governor's remarks have said so, LA County has done something similar, Orange County has done something similar. President Trump even made some similar remarks. This is not a substitute for social distancing. Fabric masks, even though I believe that they will have some impact on droplet transmission, there's still a lot of argument about the science behind that, and social distancing continues to be the primary way at which we are preventing spread and continuing to insist that people follow the governor's stay-at-home order. It's not guidance, it actually is an order, and then to follow those recommendations so that people are exposed as little as possible in making as few essential trips as they need to do. Other than that, though, that's largely the update as it stands right now. Our orders are also being extended locally, but that's largely to match the statewide forecast. Those orders could, of course, be lifted at any time. But we've extended them out just to make sure that people have a clearer picture of what they can expect, particularly for those industries which are not considered essential.
Okay, thank you. The question number 3, the medical offices are in desperate need of PPEs. We have complied with the recommendations to move to a virtual office telehealth, but there are still patients that must physically be seen, and we have no PPE to protect ourselves, staff, and patients. What help can we get from our public health department? We cannot get PPEs from the distributors.
Unfortunately, neither can we. We actually had to deny several resource requests today we ordinarily would have filled. We have made some requests of the state to get to their cash. Keep in mind, of course, that their cash is largely expired, and even those requests were denied, so we are not currently getting any support from higher up either. The logistics side presently is a seller's market, as I mentioned. Any kind of capital outlay requires terms. Some of them want money up front. The county auditor finds that unacceptable. We are working on ways of getting a performance bond system set up or working with escrow so that we can make the auditor happy and try to make sure we jump on some of these deals. But nevertheless, the sellers can essentially dictate whatever terms they want because they're the only skin in the game. We have managed to twist a few arms, but we have not gotten a lot of the stuff that we have signed contracts for yet. It's only starting to trickle in. So we are still only able to supply EMS and first responders in some hospitals right now. I don't have an ETA as when this will change, but the short-term lookout looks very limited, and it won't change until we're able to comfortably meet the needs of the hospitals before we would start moving down to tier 2 and tier 3 providers. I do want to acknowledge to people we hear these requests. Anything that gets sent up, we at least try to look at and see what we can offer to people. So it's not as if we're unaware of the fact that many of you out there in the field don't have any access to PPE, and because you're not volume buyers, are not likely to be able to make any kind of deal to get them. But as it stands, because our trickle of PPE is so limited, until we can get to a point where we can provide those tier 1 providers, we can't look at tier 2 or tier 3.
Well, thank you. Question number 4, for physicians volunteering, what can we expect and when?
The county, as many of you know, has a local volunteer program in support of the governor's health corps. We have chosen to put that program on hold. Therefore, if you have signed up locally with the county's volunteer program, please instead sign up with the state. The website is Health Corps, HEALTHCORPS.ca.gov. That's healthcorpsca.gov. And the way that it's supposed to work is as we make resource requests for staff, and we might actually be doing so soon. As many of you heard, we have a federal medical station now in the county. Federal medical station is kind of a misnomer. It's really a hospital without bodies or without a building. It's beds and some measure of supplies, and we have to staff that to actually make it do anything. About 125 of those beds are stationed now at the Indio Fairgrounds, and we plan to move the other 125 beds to a location on the West County. We're looking at a couple of sites, but we have to pass a site visit with the Army Corps of Engineers. That time frame is probably within another week or so. However, we are likely, based on whatever staffing requests that we get filled by the state, we're likely to make some further requests through the Health Corps within the next couple of weeks. Once that occurs, the state will actually notify you through its system, and then they will give you your work assignment, and then we would coordinate with you from there.
Okay. Number 5, we are looking to work with a surgery center in our community to become a labor and delivery center to keep pregnant women away from the hospitals. But it appears the county is trying to control those centers. Will you designate at least one surgery center per community to be L&D and ensure it is supplied with PPEs?
Although we have a county surge plan, which is looking at making sure that the hospitals all connect together, and I'll answer a little bit more of the question related to that later. The surge plan as it stands right now is voluntary, and we haven't really made any orders on any health facility, including surgery centers, to change scope of services. There are also no current plans to do so. So I'm not sure where that's coming from, but that's not coming from us.
Okay. If a community comes together and designates only certain clinics to see those patients that must be seen, such as pediatrics or OBGs, could we give PPEs for these designated clinics?
I don't object in principle to doing so. In fact, I think the concept seems very innovative, and maybe a way of making PPE use more efficient. But unfortunately, it would still be subject to available supply. We could certainly talk about moving it higher in the tier structure, but it would still be below EMS and hospitals. And unfortunately, I have to make sure I can supply those first. But as those resource requests then become easier, hopefully, then yes, if there is such a regional center, we could talk about seeing if we could prioritize it.
Okay, question number 7. What is your position on clinics that are still seeing significant numbers of patients face-to-face?
Technically, I'm still seeing patients face-to-face myself in the county TB clinic, although it's in a negative pressure room. And RUHS has now moved to a mandatory mask policy for patients and providers. In addition to those patients, I'd ordinarily wear an N95 mask for anyway. The reason that we're doing that low is largely because certain services in that facility are not feasible in that situation to be done remotely. And the RUHS county clinics are actually themselves going to telemedicine for almost all visits, except for a small number where physical exams cannot be delayed. And I think that the previous question pointed out is that there are a small number of visits for which that is unfortunately unavoidable. As a result, I think it would be problematic for me to order that all clinics convert to telemedicine. In the first place, I think it's unenforceable on its face. There's no way that I can enforce that over the large number of providers we have in the county. But again, simply because there is still going to be some small numbers of visits that must occur in person. We do encourage, of course, whatever clinics to convert to whatever telemedicine solution is appropriate to them. I have seen that, I know that Dolores and the rest of the RCMA group have been trying to lead that charge. And I think RCMA and CMA are in the best position to urge clinics to convert where feasible, because obviously the medical associations have the closest ears to the ground with knowing what a particular limitation of a practice would be. We'll continue to advocate that on our side, but it's not something I'm likely to make an order for unless it gets to a point where even I believe that it would be unfeasible for those small number of visits to even be done on a face-to-face basis.
Question number 8. How or are the hospitals coordinating amongst themselves to be in need-based resource sharing mode?
We have a way of coordinating with the hospitals to find out internal resource needs. The state actually is now doing multiple kinds of polls instead of us asking the hospitals and them asking the hospitals and the California Hospital Association asking the hospitals. The state is now converted to a single statewide data repository at the county level, and we have moved our data needs towards that. That said, the hospitals also discuss through their internal communication mechanisms through HASC, and I'm sure that there are other private communications which are not visible to me on the emergency response side. I think it is important for people to realize, though, that whenever a state emergency is declared, and particularly under those circumstances, the state actually requires that hospitals report up to the operational area, and then that comes back down. There's also, since this is now coming through the state actually pushes that up and sends that back to us through their databases. Officially, then this information must go up and then back down as opposed to side to side. As a result, we actually have fairly good statistics on bed capacity, ventilator, PPE, and ICU usage, other kinds of daily totals. They even have an ECMO statistic now that the state actually collects. And this has given us good visibility so we can help to predict these needs and then to coordinate with the hospitals to make sure that a hospital that's in more desperate need is appropriately prioritized. If there are any side conversations going on, though, they are not visible to me.
Was there a question number 9 that I can't read on there, Dolores, or we had, those were the 8 questions?
Actually, she sent me a question 9 just beforehand.
Oh, okay, I've got that too. I'll read it. I'll read it out loud then. Hospitals are having increasing bottlenecks with discharge of COVID, COVID plus and PUI patients with resolved symptoms, and we are using an abundance of PPEs in the face of a shortage. There is major concerns about the slowness of this process by the public health department with a rapidly approaching surge. What can be done to make the process more efficient? Please note that the SBC hold in hospitals feels to be more reasonable. Please understand the challenge this is presenting.
I do understand the challenge which it's presenting, and actually I had a discussion with our discharge planning group this morning about that issue. The health advisor which went out was almost entirely written by me personally. So I know exactly the language that I put into it. And the intention was not necessarily to hold a positive patient in the hospital the entire time if their symptoms are resolving or they are otherwise clinically stable. What I want to avoid, and I think everybody appreciates, is a situation where somebody is sent home to a vulnerable environment and then infect somebody else there. If they are otherwise clinically stable, though, then what has to happen is one of two things. If they've got somewhere else that they can go, and we've tried to make some of those resources available, they can go there and wait that out for the remaining duration of the non-test criteria. Similarly, if the home assessment shows that somebody is not in the house that's at risk, then they can just go home and wait it out on home isolation. That process actually wasn't occurring. And I made sure that I clarified with the staff upstairs that if the home assessment is clear and they're otherwise clinically stable, even if they haven't met the 7-day, 72-hour rule, they can still go home, and I want to encourage that. So to those discharges that did get held up on that, I've asked them to re-examine them, and that should try and lighten the load. As far as the general question of discharge approval goes, yes, I know that it's burdensome, but if there is the ability to avoid an exposure, especially as our counts go up, I would be remiss not to take advantage of it. We have gotten away from the CDC 2 negative tests 24 hours apart recommendation because I think that's ludicrous. They'll be shedding junk RNA for weeks. You'll never get those patients cleared under those circumstances, which is why I've tried to take a clinical approach to it and to speed it up as much as possible. But discharge approval is still going to be a fact of life, at least until we get to a point where I believe that the risk to those people from the community is exactly the same as the risk of somebody going home who may still be shedding viable virus. I don't know what that number is. Candidly, we may be getting close to it. But until that occurs, I still want to make sure that every lever which is available to me is being pulled to try and slow this down, especially for those people who they themselves end up back in the hospital and make the situation worse. But as far as the local issue with that has been resolved, and to those physicians who got their discharges held up inappropriately, you have my apologies. That was not the original intention of the order.
I missed question number 9 here. It didn't make it to my screen, but it has now.
I can go ahead and read it because I have it on mine.
Oh, okay. Why don't you go ahead and read it?
Yeah, I'm going to read it as is.
Okay.
I'll just say that straight up. Comment on Deputy Director Heidi Steinecker ordering all nursing homes to accept COVID-19 patients from hospitals, even if they are positive. Directive went out on Monday. That is a suicidal or actually homicidal order that can wipe out a whole nursing home population. Why is the health department wanting nursing homes to have a policy for in case they do not have enough PPE? We just had a visit from the health department at the SNF. When is the health department going to consider all patients admitted to a hospital as potential COVID-19 positive patients? Do they need to be reminded that we are in the midst of a pandemic? So I've just read the question straight. The long and short of it is that if a SNF has a positive case, well, we're going to be there. And I'll say it very plainly, we're still in containment mode. I know that some jurisdictions have backed off on a lot of investigation, except in really high profile situations. For some of them, I'm not aware that some SNF investigations are occurring at all. We're not in that mode. If I get a positive case at a SNF, we're going to look at it. And not to put too fine a point on it, if a SNF doesn't comply with the investigation, then I'll issue orders because those are medically vulnerable folks. I'm sure most SNF directors and whoever is listening will agree, we don't want that occurring. With each of the SNFs that we've had, we're up to 2. And the pattern we've had is a very fast means of testing everybody in that facility. In this second facility, all the staff and patients, I'm told, were tested today, and that's actually being run through our public health lab. So we should get results in a couple of days as opposed to the commercial send out. And on top of all of that, we're also blocking admits and making sure that people aren't working at multiple facilities. And for those individuals who happen to be positive, making sure that appropriate infection control measures are applied so that they are not becoming a risk to anybody else in the facility and they don't get transferred somewhere else, that they might actually bring it with them. Because of that, we were able to rapidly control the outbreak that we had out in the desert. I'm confident we'll be able to do the same for the most recent SNF, which we're currently investigating. And that's probably going to be our pattern of action for any future SNFs we have to respond to. As far as the state requirements, though, I know that there is a tug of war which is occurring between the SNFs and the hospitals in the sense that many SNFs will not take hospital patients anymore because they're concerned, or they want them to actually meet the test criteria. As far as what the state is saying about what SNFs must do, again, not to put a fine point on it, but that's the state's guidance, and that's a question for them, not for us. I do want, wherever possible, if a SNF is able to accommodate a patient, try and reduce the impact on the hospitals, and they have a SNF bed available and we're good with it and the SNF can take them, then whatever's possible for them to do, I'd like to encourage them to do so. But as far as whether the state is actually mandating that SNFs actually take them, you're going to have to ask them exactly what clarification needs to be made on their order.
Well, Dr. Kaiser, thank you very much for your time and your leadership. It's 6:28, and I know you're very busy, and thank you for your time. Dolores, do you have anything to add at all?
Just to remind everybody, we will be having these calls twice a month, same time, same channel. So please make sure it's on your calendar. We will accept questions via email to the RCMA, and if there's time permit, via the chat, but we're out of time tonight. But please mark your calendar, and we'll have Dr. Kaiser back in a couple of weeks.
Thanks very much, and we're trying to respond as much as we can. We appreciate everybody's patience with the number of cases which are out there. Obviously, it's a big challenge to keep up with. If you haven't seen our EOC, we're now occupying close to 2 or 3 floors in the county administration building with the staff responding to it, and we're trying to make sure that everybody's on who can respond as quickly as possible. So we appreciate everybody's understanding of the situation.
Once again, we appreciate all your help, Dr. Kaiser. Thank you for your leadership.
You're welcome. I will talk to you guys in a couple of weeks or sooner if we happen to have any new issues.